Hello, everyone. Welcome to the CIN discussion, Leading with Empathy. So we're looking forward to this hour today where we'll hear from two experts on how you as leaders can embody empathy to support your staff through challenging times, using those values that we talked about in a previous webinar with Empathic Inquiry. So we hope that this is going to be a lively discussion, and we encourage all of you on the call to chime in and ask questions, and I'll tell you a little bit more about how we're going to facilitate that in a minute. So my name is Marie Hubbard, and I'm the Program Manager for the California Improvement Network, also known as CIN. CIN is a learning and action network focused on spreading and identifying better ideas for care delivery. All of the work that we do with CIN is fueled by the energy and innovations of our partners and members. CIN is a project of the California Healthcare Foundation and managed by Health Force Center at UCSF. So a few things to note: everyone is currently on mute, but if you do have a question, which we hope you will throughout this hour, I'm going to ask that you just put your prompt in the chat box that you have a question, and I will call on you and ask you to open up your phone line so that you can engage in a dialogue with our speakers. So this discussion will be recorded, and we will share it in the coming weeks with you all and the rest of our network. So now let's get to the discussion. Our two speakers, we have Ariel Singer, who's the Community Health Center Transformation Director at the Oregon Primary Care Association, and we have Laurie Francis, who's the Chief Executive Officer at Partnership Health Center in Montana. So Ariel, why don't you kick us off?
All right, thank you. So thanks everybody for joining us today. I'll just say a little bit about what we plan to do together before we dive in. So what we thought we would do is start with some introductions, tell you a little bit about ourselves and our history together. And then we're going to kind of trade off in an interview style dialogue, sharing ideas and just kind of having a conversation. We don't have any slides or anything. And we hope to spend the next hour exploring the question of how we can bring a human-centered focus into not only how we interact with patients, but also how we function as leaders in healthcare organizations, how we interact with and support our staff, and how we can develop systems that are supportive of people in their whole self and how they show up from day to day. So I'll start by briefly introducing myself and then asking Laurie to do the same. As Marie mentioned, I'm the Community Health Center Transformation Director at the Oregon Primary Care Association. And I have been working in safety net healthcare technical assistance and training for the past 10 years. And before moving into this kind of work, I was a health coach at a worksite wellness program where I used motivational interviewing to provide health promotion and chronic disease management type of health coaching. And I bring that up because motivational interviewing has just been an absolute cornerstone of my work since, and is a big part of the set of ideas that we used to develop Empathic Inquiry. So just wanted to call that out as kind of my roots with this work. Laurie, would you like to introduce yourself?
Sure. It's good to be on here with all of you, and especially Ariel, with whom I worked for 6 years, and since then we've been in almost constant contact. And I started in the health center world and working on issues of health equity about 21 years ago. Started a health center in rural Montana, and then did a number of other things working with the PCA. I was an emergency room nurse and ICU nurse before that, and I feel like a lot of the things Ariel and I talk about and think about are very much related to those roots from and an understanding of motivational interviewing and how effective it was in staff, working with staff. Then I was at Primary Care Association with Ariel as the Senior Director of Innovation. We were on a team together. It was very fun. Now I'm back in Montana for the last 3 years as a CEO again of a health center that serves about 16,000 people. And I appreciate Marie's introduction that we're two experts. I feel very inexpert, especially now. Inexpert, not expert. I will say Ariel is an expert. And so I think this is really about learning with you. I feel like, especially now, the learning curve for me has gotten pretty steep again. Your turn.
Thanks, Laurie. So we thought we would start by asking each other a question that we think is very fundamentally important to patient-centered care, but also engagement in general, and is a critical element of, for example, IHI's Joy in Work framework. And that question is, what matters to you? So Laurie, in your work, what matters to you?
You know, and I'm sure this was our attraction to working together, I feel like so much of what matters to me is equity, well-being, power, control, autonomy, all those things that I really value personally and really value as a leader. And again, as I said earlier, I feel pretty inept right now in really moving to the power with versus power for. It's a huge learning and exciting area for me, but creating an equitable conversation, teamwork, solutions is really what drives me sort of daily, especially since November 3rd. How about you? What drives you?
So certainly at the root, equity and justice. And then in really, I think kind of my North Star in work is really started as patient-centered communication, but I think has expanded to be really about human-centered communication, recognizing the importance of honoring the humanity of the workforce as well as the patients that we serve. But that is the thing that I just come back to again and again, is the aspect of our work that I'm most passionate about, and really enjoy thinking about and talking about. How can we use communication methods and behaviors to convey the respect and caring that I know almost all people who work in healthcare feel, that I think often gets kind of lost in a lot of the ways that the system functions. So helping people reconnect to something that's already in them and already part of who they are, and be able to kind of bring that front and center in their day-to-day work.
I would add, when we first met, I remember talking about MI when I heard about your expertise, which I always think that's such a cool area, that our providers, when they learn how to do motivational interviewing, and not perfectly, but started to grasp that idea of sitting next to people versus opposite them, and using that skill set, it changed their ability to stay connected to their work. It changed their sense of enjoyment. So that's, I think, where we started these conversations about leadership and connection. And I'm just remembering that looking at you.
Yeah, right. So how can we bring these ways of behaving and interacting that we are convinced are not only better for patients, but actually better for everybody? So not just like the right thing to do for the people we serve, but actually the best thing we can do for ourselves as well.
Sports, we're all human.
Right, yeah, as it turns out.
Makes it easier.
So our first set of questions, what we're planning to do is actually have Laurie asking questions of me, and then we're going to switch and I will ask questions of Laurie. So Laurie, I'll hand it over to you to begin.
Okay, thanks. So Ariel, can you, I think some people on the call have probably heard of Empathic Inquiry, but not many, because it was really your creation, I bet. I mean, I bet they haven't heard. So could you tell us more about Empathic Inquiry and how it was developed?
Sure. So Empathic Inquiry is a conversational approach to conducting social needs screening that promotes partnership, affirmation, and patient engagement. And it's really intended to change the conversation that we're having nationally about social needs, addressing social needs in healthcare, from being framed in terms of data and oriented in terms of data, and instead to really focus on relationship. And it was developed through the synthesis of the core skills and concepts, spirit, and tenets of motivational interviewing, trauma-informed care, and input from many stakeholders, including both a variety of different kinds of professionals who work in healthcare, as well as many patients. So Empathic Inquiry offers behavioral guidance on how we can conduct social needs screening using a patient-centered and strengths-based communication style. And it's really intended to provide guidance to those frontline staff who are going to be conducting these conversations and undertaking these processes with patients. It also offers considerations for thinking about how you design your system and your process, knowing that you could have a really good patient-centered conversation, but if that's situated within a system that is not designed in a patient-centered way, that will be much harder to create an ongoing feeling of trust and partnership with the patient. It is screening tool agnostic, so the conversation skills are really the same regardless of what actual assessment tool you're using. And it includes a pretty robust training curriculum and set of implementation tools that we have been developing over the past several years. So its origin story is really that this idea emerged from a conversation that Laurie and I had over dinner at the Tin Shed restaurant in Portland in 2014, where she was telling me about this new body of work that was emerging to try to develop a standardized protocol for screening for social needs with patients. And that was the Prepare, the very beginning of the whole Prepare effort. And if you haven't heard of Prepare, it is a tool that the development was led by NAC with a bunch of other organizations. If you're interested in finding out more, there's a lot of great tools and resources on NAC's website. That's the National Association for Community Health Centers if you want to learn more about Prepare. But anyway, the whole conversation seemed to be really focused on like, how are we going to collect patient social needs data? And Laurie and I, you could tell from, just hearing our introductions, wanted to kind of say, hold on a second, like let's slow down and think about, well, is this just data, or is this actually like really sensitive information about people's lives and the kind of like tender details of their day-to-day experience? And it's really only data when we're looking at it from a very, very system-oriented way. And for any individual person, it's not data at all. So it started as just this idea, of two like-minded people over dinner brainstorming. And then in the years since, we've developed it through the input of really so many amazing contributors. This was absolutely a team effort to really develop it into this framework and set of guidance tools, and to help us rethink how are we approaching this and how can we really stay committed to a patient-centered orientation.
I would add, I think what we both said to that, because I remember actually outlining the curriculum on a 6-hour drive together. I think one of the things that I like about Prepare, and I think probably a lot of you are familiar with that tool, it's really important information that is correlated with good and poor health. It's also relatively intrusive, as Ariel pointed out, and in a medical setting, that power differential is so evident that it felt really inappropriate to be asking people those questions. So I really loved what Ariel brought to that conversation, is this very different way of connecting with people and not taking away the power that typically happens in healthcare.
Yeah, it feels like we have really good reason to want to connect with people around these issues that we have such clear data that these are the drivers of good or poor health. So we have really good reason to want to connect to people and talk about these things and try to respond. And we have a lot of baggage that we're bringing. I think both on the health system side with respect to our deeply system-driven culture, as well as on the patient side. I mean, one thing that we really heard in conducting focus groups and talking with patients is that these topics are not neutral for them to discuss. It requires some risk-taking for patients to disclose a lot of things around which there's a lot of cultural shame and fear and stigma potentially. So I do think it's really important to acknowledge kind of the pros and cons or trade-offs. So even if we think it's important to do and we are moving forward with doing it, which seems like nationally that's really what's happening, it bears repeating that we're asking patients to take a risk and that we really need to approach those conversations in such a way that we are taking responsibility for earning their trust and staying in partnership. And a lot of that, I agree, has to do with how do we share power in a lot of little nuanced ways.
And that patients can decline that opportunity.
Right.
In your notes, you mentioned that it feels, what makes it different from business as usual in your understanding? Do you feel like as you teach about empathic inquiry, it shifts our way of interacting with patients in general, or our history, and more, is it more focused on the empathic inquiry exchange?
Hope that it does help people think differently about their attitude towards patients and the way that they approach patient care in a more general way, and that some of the skills that we really emphasize and try to teach in the empathic inquiry training, skills and mindsets, really, that those translate. I really don't think this is just about social needs screening. I certainly think that one could make the case that these are the precepts of any good patient-centered screening process, not just screening around social needs. And a lot of it is just fundamentally about good patient-centered communication and should be broadly relevant across a lot of different kinds of conversations that one might have with a patient. And certainly this synthesis of ideas that we put together to create empathic inquiry draws on like evidence-based practices around patient-centered communication, and so should, you know, be narrowly framed, but then also be broadly relevant as well. And I think in terms of like, how is it different from business as usual? One of the things that has like really stood out to me as we have done training over the last several years and talked to a lot of people about their experience is that it is just deeply countercultural, that we are suggesting that people approach their work with a pretty different attitude than what is common from a cultural standpoint. So I think that, you know, there's individual people who, I think most people who work in healthcare, especially in safety net healthcare, deeply care about patients and bring a lot of, you know, personal compassion and caring and desire to serve to their work. And then the system that we operate in, the culture that we operate in, does not reflect all of those things. And so everyone, I think, is trying to like swim against this current of a very, very system-driven culture. And that includes having the attitude that like as a healthcare system and as healthcare professionals, that we have expertise that patients don't, that we have the answers, that we are the solution providers, that we are going to give people the resources that they don't already have, solve their problems for them. And it kind of has like this inherently deficit-based orientation. And I think a lot of what we encourage with empathic inquiry is to try to help people think about how can they be strengths-based in their conversation, because the screening tools by design are asking about deficits. They're asking about where do you have unmet needs. And so if you're going to have strengths-based conversation, you as a professional have to bring that, and you have to ask the patients about their strengths and be proactive about reflecting them and elevating them and highlighting them. So I think that is a great example of one of those kind of cultural features that makes empathic inquiry different from just how we do things. How we do things is reflected in our screening form. And then if we want it to look different, we have to be intentional about that.
Mhm. Yeah, really appreciate that. I think too, sometimes you're too generous with us healthcare people, since I'm actually like in the clinic, because I think sometimes, and I was having this conversation yesterday with our medical legal partnership, thinking about, while it is a systemic issue for sure, we individually are just such caretakers, and we're educated and we're going to help you. And so sort of taking away power in this, so we reinforce some of those same disparate sort of vicious cycles out of this do-gooder attitude, which is part of, I think, what we're learning, or it's at least in our face more in terms of anti-racist training. DEI training is really that we have reinforced in our very committed, thoughtful, kind way many of the systems that are working against people's power. And and what I love about empathic inquiry and MI truly is people identifying what has worked for you. You're the expert. What do you know about yourself and that you bring to this? And I think, I'm curious what you think about that, patient-centered care, human-centered leadership, and how you see the connection to those.
Yeah, so I think one thing that I really learned from learning and using motivational interviewing as a daily practice as a professional is that you can remake your own set of attitudes by changing your behavior. And the thing that's so powerful about motivational interviewing, and it really should come as no surprise because it's founded in the notion that we can talk ourselves into changing. So the same thing is true in terms of the practice of motivational interviewing. If you are following the behavioral guidance of motivational interviewing to constantly be reinforcing patient autonomy, expertise, strength, capability, empowerment, etc., you start to really talk yourself into believing those things in this deep way that you maybe didn't at the starting point. And I can say, I'll just speak for myself that I didn't at the starting point because of these cultural things. We go into these professional roles with the training and messaging that we have something to give people, or that we're there to provide them with expertise that they don't already have. And I think that we can all start from trying to behave differently and to focus on changing our way of interacting to emphasize that what we can offer is expertise in facilitation. Essentially, we can offer expertise in partnership. We can offer expertise in curiosity and empowerment, and then work with patients to help them achieve what they want. And I think if we just keep trying to do that over and over again, eventually we will remake our culture. And that it's kind of hard to do it the other way around. Or maybe it's like a both and kind of simultaneous thing.
Yeah. I always find the term empowerment interesting. I'm questioning so much these days, but the idea of, is empowerment really just moving out of the way and leaving people with the power they already possess? Or is it actually distilling, helping invest in people's ability to do things? And I think MI actually does more of the latter. Is that true?
I think so. And I think that's connected to the whole idea of self-efficacy. And I think that it would be cool if all we had to do was get out of people's way. But I think we've had a really effective system for keeping people down. Oppression has been pretty effective.
For 600 years or so.
Right. And so I think just getting out of people's way maybe won't accomplish it. I think maybe we have to be more proactive in saying, not just we're going to get out of your way, but no, we really mean it. We really do want you to take your own power and use your own agency.
And work on ourselves in our, that's good. So as you think about what you are so expert in, and yours and my past conversations, how do you see this translating to leadership? And then I can add to that, but I'm curious what you saw the connection.
Yeah, so one thing that I felt was important to name in this webinar is that we have provided empathic inquiry training to about 250 people at this point, mostly community health workers, medical assistants, resource specialists, behavioral health case managers, nurses, and other kinds of clinical support staff. And we've pretty consistently heard from participants across the trainings that we've done in different states and different settings that people wish their organizational leaders would attend this training, and that there is some kind of gap that persists between what we're asking of the workforce. And obviously these organizations do want to ask out of their workforce. They're sending these people to this training. But there's a gap between what they're being asked to do with patients and how they themselves are being treated within their organization, or how they see other people in their organization treating patients. And to me, I think the question is, how can we do a better job of leading by example and not pushing the responsibility for human-centered interactions and trauma-informed practice down to the frontline staff, and instead figure out how can we all have a sense of shared responsibility in creating this kind of culture, modeling this type of behavior, and really thinking about what does it look like to be consistent. And everybody who talks about trauma-informed care talks about the importance of leadership and the importance of like how an organization treats employees. So you really can't ask people to engage in trauma-informed practice with patients without creating a trauma-informed workplace. So, you know, this is nothing revelatory, but it's just a really persistent gap. And that I can, you know, even from organizations where I know the leadership is really interested in trauma-informed care as a way of approaching the interactions with patients, and still the staff from that organization is saying, like, our leaders really need to hear this. So I think that I'm really curious to chat with you about your perspective as an executive director and as someone who's been in leadership roles for many years, how we can start to close that gap and have a more seamless way of conducting business. It's human-centered and elevates these values that are so important to us.
Yeah, it's definitely a work in progress all the time, but yeah. I would just add, as we turn the tables a bit, I think one of the things we forget when we say communication, so often we think we just have to be clear when we talk to you. I feel like that's sort of inherent in leadership. Like, if I can just communicate really well with Ariel, she will do exactly, as opposed to listen really well and incorporate really well. And I think we miss that often in leadership, with the sense that we need to know it all. And we miss it in healthcare because we're the experts and the patient is not, which is exactly the opposite, right? But yeah.
Yeah, so it's kind of like some of the same dynamics being mirrored, where like leaders expect of themselves to like have the answers and solutions in the same way that healthcare professionals do. And in doing so, aren't actually like staying oriented towards listening and partnership and collaborative solution finding.
Yeah, I think that's exactly right.
So I'm curious to hear your thoughts. How do you think leaders can embody and demonstrate or convey the values and principles of empathic inquiry?
I have a number of thoughts, and I'll share those. I think one of the things I always, when I do talks like this, I've done a number over the years, and I always feel like, I wonder if any of my staff members are listening, and I wonder what they would say, because I always invite them. But so if you're on here, I don't sing any names, but I always wonder, sort of like you were pointing out, often I'll say, oh, we're doing this and this, and people will come to me later and say, you know, we're not actually doing that. Like, really? I thought, and so I will preface it with that. And then I feel I really like a lot of leadership things, and I think that knowing what goes on in an organization of any side at all the levels, really hard to make sure we're doing what I say all the time, every day. In fact, I know we're not. So I'll just say that as well. But as I mentioned earlier, I love MI stuff. I love what you and I have talked about with empathic inquiry and learning from you. And then the concepts that are about respect, relationship building, power sharing are just humanistic concepts, right? they're nursing concepts. I'm a nurse and by training, and I love that about my life, and bringing those same sort of affirming behaviors to all my work. And I think in leadership, we often just feel so cornered. I will tell you, being a CEO, and there's probably a lot in this call, this sounds stupid, but it's kind of lonely. It's sort of isolating. And so it's very easy to feel like you have to put up the barriers. And when I do that, just like providers, I lose my connection to the work, and I just don't like my job. And so this idea of psychological safety that's inherent in empathic inquiry, MI, is what I desire, I try to bring to the work I do, to never expose people's insecurities, ever. I say that in meetings all the time. Don't ever call on somebody and ask them to show their insecurities in front of a group. Don't do that to me. Don't do that to each other. Try not to trigger each other when we get to know each other. We talk a lot about this. We talk about activating events in our meetings all the time, and we have people do this, like the way you just said that. And so going, oh, I could do that differently. And really trying to flatten that connection with all staff, that we all are equally valuable. We're all equally valued. And I really do believe that. I think sometimes people think that's a little weird, but I think each of our jobs is incredibly important here. Like MI, the strength, and empathic inquiry, the strengths, really focusing on strengths. So the concept, I think a lot of you know, this is strength-based leadership, right? Focus on what people are good at, focus on what your organization's good at, and we do this all the time. And I think sometimes people view that as avoidance. It's not. It's saying, what do we do well here? Let's keep doing it better. And what piece are we not doing as well as we'd like? And let's bring that in. And I'll talk about that with the staff engagement a little bit. And then, excuse me, and then fostering connections with the mission. I feel like I'm lucky that all the places I've worked in the last 22 or 3 years are very mission driven. And so our whole goal is to improve health equity here. And people get on board that easily and happily, especially if they believe it's authentic. And that involves each other. I'm gonna have to cough, sorry you guys. It's not COVID, I promise. Although I could go downstairs and get screened. So that connection to mission, I find, is really creates a sense of psychological safety. So that's what I would say. Avoid triggers, focus on strengths, and connect people to the mission. And then another aspect of empathic inquiry is power sharing, right? And so I think about that a lot. I feel like I'm decent, but not great. And so what does that look like? And I shared this with you, Ariel. It's like really co-designing answers and solutions. So that's like sitting with the patient, right? And finding out what does the patient know, what do I know? And in co-design, we sit with staff and patients and say, what's working and what's not? And you guys are the experts in your jobs, you're the experts in your lives. What needs to change, and what strengths does the organization have that we can bring to that? And I think often my job in that is like just to say, cool, that's such a good idea. Or sometimes more difficult, I don't think we have the resources. What other ways can we do that? So again, co-design is something I actually learned from some folks in California and found it really, really helpful. There's a facilitative leadership concept called maximum appropriate input. So we use that all the time. We probably are overly inclusive. So every meeting has like 50 people to make 2 decisions. I think we could be a little more efficient, but for now we'll keep erring on the side of having, and we always say you don't have to stay at the table if it's not interesting or engaging to you. I do wonder about the word appropriate, actually, especially now when we think about inclusivity and who's appropriate. And I don't think I know the answer anymore. It's something that I'm sort of questioning in my own thinking about who belongs at that table. Transparency is a big way to foster power sharing, celebrating successes of all the people in this organization who contribute, valuing all voices, and then moving from a blame culture, which hopefully most of you aren't living in, but I think that happens often, to a system level focus and an individual level connection. Really, how do you improve the system that created that outcome? And I'll talk a little later about what we know about evidence-based leadership and human motivation in the context of leadership. So I think it's just like EI. It's fostering respect and building trust, right? And it really is. I have a quote on my wall that says progress moves at the speed of trust. And that is so true. When I got here 3 years ago, I was ready to move. And people are like, who are you? Like, slow down. And experienced that before, but it was a really good reminder. You can't just, I feel like I'm trustworthy. That doesn't mean people trust me, and they don't know that I trust them. So I feel like, and it would be really hard to change a culture that didn't have that. I've tried to do that, but I am really lucky to work in a culture that trusts people and asks for honesty.
One thing that I really so enjoy about you, Laurie, is how clear your North Star is in leadership, and how I think it's so powerful. Like, you know, as we said at the beginning of the conversation, Laurie and I have known each other for like 8 years or something. And I think the commitment that you have to these ideas and the persistence that you have, and kind of just like coming back to them, like you have a clear set of touchstones, you have a clear set of beliefs, and that the like kind of persistence and repetition is incredibly powerful. And focusing on mission and vision and values, and really thinking about like, how can we live those out? How can we take the risk of being inefficient in order to be inclusive? Like, that's not a risk all leaders would take. I mean, there's a really strong emphasis on efficiency, and you're clear within your values paradigm that like inclusivity is more important than efficiency. And so you make choices in accordance with that. And I think that is very, very powerful, to have such a clear set of concepts that I know, you know, you are also leading on reliable methods. Like, these aren't all things that you have developed yourself. Like, you're a learner in leadership, and like have introduced me to all kinds of leadership paradigms and concepts that are so powerful to be able to like pull on tried and true methods and think about like, how can I take these things that I know in my heart to be what we all need to thrive, and then take action guided by those things as an organizational leader.
I think the two things I'd say about that are, I mean, I've learned a ton from you, so that's been a lovely part of our relationship. The thing about, it's actually not mutually exclusive. It's kind of like I can walk and chew gum at the same time. Sorry to quote that. But you actually can't, I believe you can't be non-inclusive and efficient. Those are, you can't succeed in a health equity or health justice conversation or outcome by excluding people. So it's much more efficient to bring all the voices to the table. And I think we know that actually intuitively, like you're saying, we know when we're not at the table and we're so used to being powerful, we feel excluded, we feel slighted, and we're just like everybody else. And so I think I probably said this to you years ago, if I thought autocratic leadership worked, I would totally do it if it meant that we could improve health equity. I just know it's the opposite of that answer, that if you have equitable relationships, power in organization, strength-based approach, love, connection, that's how you improve health outcomes, internally and externally. And so I feel sort of like a sociopath. If I thought we could get to health equity differently, I would do it. It's just not possible. So
A sociopath is obsessed with health equity.
What's that? I know. I
Right.
do. For me, when I feel lonely, dying in COVID, and I remember partly all the things I'm grateful for and how lucky and fortunate and privileged I am. And then I go, okay, what do I know to be true? And I know people get on board. We all really believe in, I think, I will hold on to this, the value of all human beings. And when I go back to that, so how do I go back to that touchstone when I'm feeling demoralized or overwhelmed or attacked? What do I know to be true? And that's how I get through those tough junctures over and over. It's just my security blanket.
So we have some questions from the group. I'm just gonna call on a few people to chime into the discussion. So Paula Lozano, do you want to chime in and ask your question?
Yes, thanks, Marie. Ariel and Laurie, this has been a really interesting conversation so far. My name is Paula Lozano. I'm a pediatrician and Medical Director for Research and Translation at Kaiser Permanente, Washington. I am just so interested to be thinking about motivational interviewing in the context of thinking about leadership. I was first introduced to MI about 15 years ago, and I'm one of those clinicians who learned it, and it just like blew my mind and changed not only the way I interact with patients and families, but also with my partner, with my children, with my coworkers. It's one of those sort of transformative experiences for me. My question for you is about managing up. So I see the connection between the kind of empathy that MI skills can engender and how powerful it can be in the workplace. And I find it really effective with my peers and people on my team. But boy, if you have a boss or you're on a leadership team where other powerful people in an organization are hierarchical and not really good at listening and all of those other behaviors, do you have any tips for how to start changing the culture at that level of the organization?
I have thoughts. Ariel and I actually shared some experiences around that. And so, Ariel, would you like to take a stab, or would you rather have me?
I'd like you to go first.
Okay. First of all, thanks for the question, and I love pediatricians. I was talking with a friend who's a doc, and we decided like 98% of pediatricians are just naturally great people, and it goes down from there. So, I think we're naturally human-centric. I think pediatricians are, the way they're attracted to little humans and to parents is just incredibly loving, I think. So that's a good place to start. Do you work with Katie Coleman?
Yes, Katie and I are partners in crime.
We are with her too. So we're
yes, I know. She's the one who sent me the link to this meeting.
Okay, so then managing up, it was a term I actually didn't know. Talk about power. It was a term I didn't know until I joined OPCA, because I'd been a CEO for 14 years, and then I stepped into a different position where I wasn't the CEO, which was actually a huge relief, 98% of the time also. And so I have been the CEO most of the last, and I found it sort of like a weird term. And then the more I watched my behavior, the more I understood it. I think when you have, I might let Ariel, so I guess the thing I could say in the situation that I experienced is that role modeling, I think very often, I'm watching this here. So I'm working with two different people, one who's the head of facilities, one who's in another position, no experience being anything but hierarchical. That's what you do when you are a leader. You have to be smart, double smart. You have to tell people what to do. And you have to be hard ass, right? Excuse my French. And I watched this play out here, and I've watched this person change 180 degrees by just coaching at every step of the way. So a different way to do that might be, a different way to include that, setting up an agenda so that the agenda is very explicit on what the behavior, what happens with each element of the agenda, what the goal is, how you foster conversation versus make decisions unilaterally. So I have some tools I could share with you, Paula, that I can show you what we do, and what in my CEO role, I can actually command that we do it differently here. I get that worked in your old life, but here we do it differently. So I don't know beyond that, role modeling and giving tools. The Institute for Social Change, Interactive Institute for Social Change in San Francisco, also in Boston, is what I have put every leader I know through. And all of Montana went through it, and most of Oregon went through it when I was there, and a lot of our staff went through it at OPCA. And it's game-changing for so many people. And I heard that from all our staff here. They're like, I have never attended a better leadership program. And I think because it allows you to be human again. You get to drop your defenses. You get to speak with your peers instead of being this amazing leader who has all the answers. And so I think it really helps people connect with their team, which again, I said it's isolating to not do that. So I don't know if that's helpful. I can send you those links too. Ariel, do you have thoughts on that?
Yeah, a couple of additional thoughts. One of the things that in the motivational interviewing training community, people always talk about is that you have to use motivational interviewing to teach people motivational interviewing. So some of what occurs to me to think about how to convey some of these ideas is to try to share new concepts and ideas. I 100% agree with Laurie that like using methods is really powerful to reshape a system, and facilitated leadership was incredibly impactful for me. But just as in motivational interviewing, we try to minimize ourselves as an expert, and maybe even if we're sharing some ideas with patients about things they could try in terms of health behavior change, we might frame it in terms of like, these are some things that have worked really well for other people, or some of my other patients have told me that this was really powerful for them. So it's not like me, the expert, telling you what to do. And so I wonder about looking for leadership methods and paradigms, and then kind of introducing them in that way of like, here are some really powerful evidence-based methods that we might want to consider using to help drive our effectiveness. And I always come back to like, how can we, and this is what Laurie was just talking about, how can we be clear about like, what are our shared goals? What are we collectively working towards? And can we bring some can we have a conversation about like what's going to be most effective in helping us get there? And that maybe by like kind of leaning on the credibility of other people and kind of the authority of tried and true leadership methods, it's a way to kind of introduce it that is, regardless of what your power position is, that you can bring that in a non-threatening way. And I guess I would just say, I think it's a really hard, that issue of managing up or like trying to operate in a system that you feel is inconsistent with these kinds of cultures and values, and you don't get to lead those changes. I mean, I think that's a really tough thing to do. And I also agree with what Laurie said, that like just being clear about like, well, what are your personal convictions and the way that you want to show up, and trying to just like be really consistent about modeling those. And again, just kind of leading by example, and being like, one thing that I know about Laurie is that like, she's really predictable. Like I said, she's very consistent. Like I know what is most important to her, and that the conversation is always going to come back to health equity. It's always going to come back to power sharing. It's always going to come back to humility and engagement and lifting up other people and focusing on strengths. And I actually think that's been enormously powerful to me, having had her as a leader in an organization where I worked, as a mentor. It had a huge impact. Just that really persistent voice, like always coming back to that and raising that. It's like, this is what we should be focused on. And I also think that it's in part powerful because there's kind of like a moral imperative there. Like it's really hard to argue with. Like if you're always coming back to health equity, especially in like, settings where we're talking about safety net healthcare or health disparities, like nobody's going to argue with that. Right. As like our central focus. And so it really helps to kind of reset the conversation or reorient us.
Mm-hmm. Thank you.
Mm-hmm.
Well, I would say too, healthcare is hierarchical. You know that. You guys, your whole training is like, let's do some blaming and shaming in front of everybody. And so, and I would also say probably that person who is hierarchical is as insecure as any of us in the room, and therefore living in fear, same thing. And how to partner, not your job necessarily, but to connect with that person, knowing that they're as human as you, and probably less capable in many ways. And so how we bring people out of that shell and allow them to be human is really a big deal. And afterward, I'm happy to share 3 or 4 tools that you could role model and show, if this person's open to that, and for yourself, that can be really quick in helping us see how to do things differently in a room, in a team setting.
Thanks very much.
Sure. I noticed we have 5 or 10 minutes, is that right?
We do, and I know there's one other question that the group wanted to ask. So Megan, I invite you to open your line and ask your question of Ariel and Laurie.
Thanks so much, Marie. And just really, I'll be brief. I know that in groups like this, in leadership groups, and as we're training staff, we all want to have this sort of empathic communication, this patient-driven care. But when we operationalize it, things tend to get lost in the shuffle, especially at community health centers. Who's doing this? When are they doing it? With what time? And I think a lot of the reason we defer to these, paper screenings without the conversation is just because of time. So how have you been able to operationalize this in a way that's sustainable?
Well, it's like, you probably live this like I do. It's like all change, it's all improvement. Where they say all change is not improvement, but all improvement is change. And piloting it, we did this in Oregon as we started to roll out Prepare. We didn't know how to do it. We still don't know how to do it in the country. So do it with 10 people. Do small pilots. You make sure there's an end date. We have 5 domains that we focus on here. One is joy at work, quality, access, operational excellence, and innovations, and population health. So we don't sacrifice one for the other, ideally. So if you're rolling out an idea, if you're rolling out Prepare and Empathic Inquiry, you're not going to sacrifice joy at work. And joy at work is, for most people who work in health centers, is about making a difference in the world, thankfully. They're really here because they want to see change. And how you honor that, know that they don't want to not do it. They just want to do it well. They want to be masters. They want to have autonomy, and they want to contribute to the mission. And that comes out of Drive and Daniel Pink. And so I think you really have to pace change. And Ariel will tell you I'm one of the worst. I like to do everything tomorrow. And like, come on, it's time. And so I have to listen to the staff around me who say, we actually can't handle one more ball in the air. This isn't working very well yet. So I would say pacing, listening to the people, which is your staff. There isn't anything that's an emergency. It's somebody coding in your office, right? And I think so really thinking about how to create a change that's sustainable. And what we know about change in groups is that they need a success, an early success. They need to feel like they can. So you start with really low reaches. You do for one day, you celebrate, you tweak, you go back to day 2, you celebrate, you tweak. Ariel, do you have a different thought?
Well, just something to add. I mean, I think the other thing that's really important for us to remember is that we do not have to have the whole conversation and address all the needs today.
Yeah.
We just need to establish a relationship and focus on engagement and building trust and partnership with the patient. So even if the follow-up conversation is just like 5 minutes of saying like, I see that you answered some of these questions in a way that, maybe you could use some support. I'm wondering if you'd be willing to talk to me about that for a few minutes. And just trying to hear some more of someone's story and then saying, I think there might be some ways that we could potentially work with you to support you in this. And would it be okay if I follow up with you and we talk more about it at another time? One of the health centers in Oregon that has been really successful in implementing a social needs screening workflow, I think really was focused on like, we're just going to start, our goal is to have like a kind of a warm handoff to a community health worker and not have the expectation that like they're going to have the whole follow-up conversation in that moment, but that they're just going to start with connecting. And maybe you have a conversation about like one aspect of the patient's experience, and then you pick that conversation back up on another day. I think this is something that we get into trouble with a lot in terms of responding to patient needs, not just with social needs, but also like in all my motivational interviewing training experience. This was a thing that I also would hear from trainees in terms of like wanting to get to a solution today, right now, like being in a place of moving faster than the patient is actually ready, willing, and able for. And I think in this case, that's in terms of behavior change, but in this case, it might be also like trying to move faster than the system is really ready, willing, and able to do. And that if we just really focus on, this is my conviction, that if we focus on building trust and building relationship, that first of all, that has inherent value. And that we can convey something positive and facilitate a sense of like support and caring without actually doing anything material. And that we can have the beginning of a conversation and then we can pick it up at another time. And, you know, if we have the trust, if we have the relationship, then that's there to come back to. And I think it's kind of the same, it's like the patient. So Laurie's answer, I think, was on the organizational level, and my answer is on the patient level, but they're essentially the same of like, the immediacy is less important than the trust and the relationship. So it's like going back to the progress moves at the speed of trust thing. And again, like this is my conviction and my North Star, that if we focus on relationship, we will succeed. And that if we try to do things in a way that's oriented towards like efficiency or, you know, maximizing our reach without focusing on the quality of the interactions that we have, that we will probably help some people, but we also might harm some people, first of all. And there'll be a lot of missed opportunities in there for sure. Do we have time? I don't know if we have any more questions or if we have time for any more. I know we have about 5 minutes. So if there's no more questions for the group, I think I want to ask Laurie one last question.
Go for it.
Okay, so I think, Laurie, what I would want to ask you is what would you say for folks in the time of COVID and major social instability? What are the things that you come back to and that have carried you forward in the past few months?
I'll say in 3 minutes, but like I think about, and I have a few other thoughts about the last question, but I'm not going to do those right now. What's carried me forward is what you focused on, is that, you know, I think the disruption that came out of COVID that we've all experienced in every single way in our lives is humbling and puts us maybe on equal footing of other people who have had tornadoes in their lives, their whole lives. I think we came out shell-shocked. I think that what I was thinking as I was thinking about this thing is, what my overwhelming thing is, don't miss this opportunity. Do not, everything got turned on its side. Don't miss the opportunity for huge, dramatic shifts in power, in equity, stuff that we're no longer mired in what was, because we sort of threw it all out the window out of requirement. It's now coming right back to where it was. It'll congeal just the way it always did, unless we really seize the moment. So we created a innovations group nationally to kind of, how do we seize this and really carry it forward in terms of really embedding equity, really changing our approach to DEI, really incorporating, really leveling the playing field. And so for me, what I hold on to is the hope that things will be very different out of COVID, and that I hopefully have a role in like holding on to that alternate future that is much better than the one now. And some of the things I shared with you, Ariel, that I'd love to share with the group, but I won't now, is some of the recent readings I've done, and one that was just in New England Journal of Medicine by Brian Parks and others, is co-creating a thriving human-centered health system post-COVID that is so cool and touches on all the things you and I talked about. So I just feel like we're using our intuition, evidence, and leadership to really create a better world. That's what's kept me through. Every time I have an assault, like the third, I just hold on to what can we do differently.
Thank you so much for the enlivening conversation. Always such a pleasure to talk with you. I'm so grateful for the California Improvement Network creating the opportunity for us to talk today, and for you agreeing to do this with me as my favorite leadership and patient-centered interaction pal. And maybe we can work with Marie and Christina to send out some resources. It sounds like you have a few things that could be useful to share. And we can send that to maybe the people who registered today.
Sounds good.
Yes,
Thank you guys. Thanks everybody.
absolutely. Yeah, thank you so much, Laurie. Thank you so much, Ariel. This has been a wonderful conversation. And thank you to all of you who joined. We will be sharing the recording as well as the resources that Laurie and Ariel talked about in a few weeks. And we look forward to seeing you on future CIN webinars and discussions. Thank you again.
Thank you. Bye-bye.
Bye.